All right, good evening, everyone. I hope you're having a good meal. Just wanted to welcome everyone to this year's annual fall meeting. As you're aware, this is the meeting where we have the resident presentation. So thank you to the residents who volunteered to present to us today. I also wanted to thank our exhibitors, Interpace Diagnostics and Caris Life Sciences, and hope that you got to meet up with them outside during the reception time. Excuse me. And then a networking reception already happened according to our agenda. We're already eating dinner. And then we'll have the two presentations starting with Dr. Allen and followed by Dr. Lee. And then we'll move on to our business meeting and adjourn. And I also wanted to welcome Dr. Swanson, who's our current president. And with that, we'll transition over to Dr. Allen.
Thank you, Carmen. And good evening, everyone. Please continue, feel free to eat. I understand. I tried to snarf mine down too before I got up here. So can everyone hear me okay? Okay, perfect. So thank you for the opportunity to speak with you tonight. I'm going to be presenting a project that I've worked on for the last 2 years with one of our faculty at UNMC, Dr. Stan Radio, and our team of internal medicine specialists. The project was the effect of LVADs, or left ventricular assist devices, on the propagation of coronary artery disease in explanted hearts. So just a general outline of what I'll be going over tonight, a little bit of background on LVADs and heart failure as a disease, going over the methodology and why we tackled this project, the results that we found, discussion, and then future thoughts. And of course, as a resident, I have no financial disclosures or conflicts of interest. So every project starts with an issue to address and then questions that are tied to that issue. So therefore, our issue of the day, if you will, because I sound like I'm on Sesame Street, is heart failure. So heart failure is a chronic and progressive condition that affects roughly 6 million Americans over the age of 20 years of age. About half of these cases involve reduced ejection fraction, or the reduction in the amount of blood that's pumped out of the heart with each contractile motion. So clinically, we think of that as less than 40% being tied to a reduced ejection fraction. Now, we can further categorize heart failure, or even cardiomyopathies overall, into non-ischemic and ischemic diseases, or simply that relates to the coronary flow and the reduction of blood flow to the myocardium that then leads to subsequent injury. So with approximately 10% of the population progressing to advanced stages of heart failure, we arrive at our first question of the night. How do we aid this pervasive process? So we can perhaps work to counter risk factors, when we think of things that may lead to heart failure, and these being things like hypertension, obesity, or other unhealthy lifestyle behaviors like smoking, tobacco, poor food choice, limited physical activity, excessive alcohol intake, etc. But along with tackling these issues, historically, heart failure with reduced ejection fraction has also been met by medication options, those being angiotensin receptor inhibitors, mineralocortical receptor antagonists, beta blockers, SGLT2 inhibitors. That's more of like the quadruple therapy that we characteristically use for these patients. Now, in the 1960s, though, many thought of a better option at the time, and that was with a mechanical support system. And so this was more evident to cardiac surgeon pioneers at the time, who in 1966 proposed and implemented the first LVAD, or left ventricular assist device. So it's an option to restore functional flow to a failing, or through the failing heart. So the idea, as we see in the pictorial, that you insert the device into the left ventricle, and you flow around the failing heart and into the aorta, and then allow it to continue to pump. Now, this is not something at the time that was thought to be everlasting, that this was just a bridge to help these patients continue on until they were able to meet needs for transplantation. It was then decades later after improvements that the FDA actually approved the first LVAD to be used as a bridge to transplantation. Now, that was in the 1990s. Now, we arrive then at our second question of the night, other than how to bypass the issue of heart failure with the LVAD, are there any consequences in altering physiologic flow through the heart with a pulse, or altering that physiological pulsatile flow of the human heart? So this is really where our project begins. And so we thought to ourselves, are there reasons that by altering the flow, would you alter flow through the coronaries, the native coronaries? And would that be effective to these patients? Now, what Dr. Radio was observing on his explant hearts over the years was that even in patients with non-ischemic disease diagnosed prior to, when he explanted these hearts, he was noticing that there was an increased deposition of atherosclerotic change or coronary luminal narrowing. So he scratched his head thinking, is there something about this device that even in those with ischemic disease prior to, if you're still non-ischemic, is the actual going around to the top of the aorta and minimizing the actual native flow leading to increased disease? So that's kind of where, answers involve a journey. So we started this off way at the beginning and then started to investigate further. So the methodology that we employed, we gathered the coronary artery tissue samples that were available in cases January 2015 through August of 2023. This was to meet the deadline for our USCAP submission of that year. And we looked at cases that had LAD, or so left anterior descending, left circumflex, and right coronary artery H&E slides. And these had all been previously reviewed by a cardiac pathologist. And so we used those as our initial group. We then performed demographic comparisons and risk factor examinations to see if there were any potential confounds in that group. We removed any that demonstrated signs of allograft vasculopathy. So the big thing that we were looking for was a difference between what would be a concentric luminal narrowing versus more of an eccentric luminal narrowing. And that was conducted by Dr. Radio and myself moving forward. But that gave us our two populations that we worked with moving forward. And so this was our 70 samples within our test population of non-ischemic cardiomyopathic patients with an LVAD implantation prior to their transplant, and then the control being those with non-ischemic cardiomyopathy who had not received the LVAD. And again, that sample size is 19. And so we have our groups, and now we get to the lovely mentioned statistics where everyone kind of rolls their eyes. But for what we had to do, we performed semi-quantitative analysis. So anyone that's worked with Dr. Radio in how we assess our coronaries, we perform it on a grading scale by luminal narrowing. And this is very much by the pathologist's trained eye. So we took these and we categorized them into groups 1 through 5. And then from that, we were able to perform non-parametric assessments on the differences between the two groups on their averages of those scores. So again, you're comparing two groups, so that's consistent with a non-parametric Mann-Whitney U-test. And then further statistical analysis on a semi-quantitative analysis realm was conducted by comparing time with the LVAD placed. So the question there was, are these people with, this placed longer? Does it lead to a greater luminal narrowing? So we separated that out into different time comparisons. And likewise, we looked at patients with risk factors for heart disease, and that was specifically hypertension, hyperlipidemia, type 2 diabetes, and tobacco use history. And then we categorized those patients by numbers. So if you had 1 versus 2 risk factors, 3 versus 4, you got placed into categories. And then we performed Kruskal-Wallis H tests. So it's more like an ANOVA test that we're used to, but that's, again, within a non-parametric setting. So that's kind of the initial approach. Now, after sending this and getting it returned to us by our initial editors, they said, well, the pathologist trained eye may not be good enough. Do you have a way to digitally assess this? So I talked with Dr. Radio and he said, well, in theory, sure. So we scanned all cases that had available MOVATs and VVGs to be able to identify the internal elastic lumina and then moved those into Photoshop, where you are able to calculate the area by drawing individually all of these out, and then calculating by the calculation that I have shown here to give you an overall luminal narrowing, and then could compare that. So that was then performed as a parametric student's t-test to compare the differences. So now we have a semi-quantitative analysis, and we have a digital quantitative analysis to go along with our findings. So again, this is just to really show, and I can step away, to demonstrate what we were working with. So on the top row, we have a left anterior descending. Bottom, we have a left coronary, or a left circumflex, I'm sorry. And these are just representatives. We did choose these because they're probably the most round. As we all know, some of these kind of displace when we cut, or it's just the nature of them fixing that they kind of fall together. But again, we see from the H&E how the pathologist could assess luminal narrowing, but then with the actual special stains, you can highlight out the internal elastic lumina, and then again, circle that area, minusing out the drawing of what is this lumen that is made from the disease process. So in the top, I believe the estimate was within the group 51 to 75. And the bottom demonstrates a luminal narrowing of 75 to 90%. And again, these are with MOVAD stains. So just to give an example of the work that was put in. So now we get to the results. So we show that the demographic and comorbidity information associated with our testing control group demonstrate no large significant difference. So again, the only significant component was the difference in smoking between the those with LVAD versus not LVAD. But again, just to really identify, are there big confounding variables that are impacting things? So we really didn't feel that these were large confounds moving forward. Now, when we actually look at the results from the statistical analysis, so we see, again, the average coronary luminal narrowing across all of those, the LADs, the LCX, and the RCAs, averaged out and then compared between the groups. And we see that those without the LVAD had less luminal narrowing compared to those that actually had the LVAD, with a p-value of less than 0.001. When we look at the time, however, it's a little bit of a head scratcher, because one would assume that the longer you have this, that the longer you are not maintaining a flow, that things should develop. We didn't really see that effect based on our statistical analysis, that there was no real statistical significant difference across time zones or time, implantation time. When we look at the digital, again, we see a similar result compared to what we had above with the semi-quantitative. So again, we have that comparison to demonstrate that digital is, in a theory, as good as the pathologist's eye. When we look at risk factors, again, as I noted, we took individuals that had no risk factors, 1, 2, 3, 4, stacked them up, went with their average coronary luminal narrowing, and looked to see if there was any statistical significant difference. We did not see one based on our analysis. So, in summary, we asked our questions, we investigated, and we found that there was increased coronary artery luminal narrowing seen in those previously diagnosed with non-ischemic cardiomyopathy, having received LVAD as a bridge to transplant. And this was seen both histologically as interpreted by a pathologist's eye and with digital calculation. Now, within anything, there's always room for discussion and a mention of your limitations. So, considerations that were proposed by our editors and that we looked into: are there concerns of different LVAD models? Not all of these LVAD models work similarly. Some of them just perform on a continuous flow, while others have a co-pulsitation or a counter-pulsitation model to make sure that some flow moves back down into the coronaries. So you have these three models. Now, when we look at our cases, 94.1% of them were a continual flow. So meaning you're not getting that backflow back into it. So it kind of suggests that that may be why we're seeing this effect. Now, again, the question of the computer modeling versus the trained eye, that falls back to, our editors making us go back and see. And again, our results demonstrate that there are comparative results between a pathologist interpretation and the computer modeling of this narrowing. And for part three, for any of us, again, as I mentioned earlier, that have worked with Dr. Radio, he is very adamant that when you cut, you want to make sure that your cut is a full, circle. You don't want wonky cuts where things are kind of distorted. Now, you can do that. You can do as perfect as you can. However, you also have to remember that this heart sitting in a bucket is not under pressurized fixation. So no matter what you do, sometimes some of those vessels can fall or, distort. So obviously for future studies, you would have to have a pressurized system. And I see how. So he told me that a lab that he knows does this, where they're actually connecting flow circuits into the coronaries. I don't know. That's what he told me. But it seems pretty over the top if unless you're in a research setting, you know. But that is one way that you could counter that. But it is something to consider, could that be an area of limitation or difference in what we were seeing? Now, the bigger limitations that I will mention, so we don't have any samples prior to the explant. That's kind of just the way the nature of this project is. I mean, you can't go in and resect someone's coronary, you would assume. You're also going off of medical record history. Now, I will not lie that when you go in there, it is all over the place between how they define ischemic cardiomyopathy versus non-ischemic cardiomyopathy. I saw patients that went from one to the next to the one to the next. And so you're kind of left to what is the clinician describing and how can we extract that from the medical record to perform the research that we're doing. So it is a limitation. And again, then you don't have that direct temporal comparison between before and after. Now, again, we are a single center. As an institution, we can have institutional effects that could affect this. I think that also feeds into the fact that we had one pathologist performing all of these assessments. Now, that one pathologist did meet comparison-wise with the digital assessment. So, I mean, good job for Dr. Radio. But would that then be the same for all cardiopathologists across the board? I don't know. I mean, he'd probably say yes. I don't know. And then also limited sample size. So obviously we could have expanded this out to a larger sample size, but then when it ran into meeting the needs for special stains and pulling blocks and getting things ready and assessed, you're kind of running on a time crunch. But obviously moving this forward, yes, a larger study would be perfect. If you could do multi-institutional, it'd be even greater. If you had multiple pathologists to then confirm to make sure that everything was working hunky-dory between things. But again, this was a limited study, but these were our findings. So again, what does this really mean moving forward? Well, I think it suggests that with these older models, and as I showed, the group Lee et al. Also demonstrated in a very small setting of experiments that this continual flow also showed deleterious coronary structure, that this is a model that should probably be moved out. They do have newer models, as I'm saying, with copulsatile and counterpulsatile models. So moving those for better patient outcomes, especially now that we've kind of moved from a bridge to transplant model, and we're trying to use these more long-term, that they're not necessarily just used for a small window period, but they can be used longer. So ultimately, providing this data is a small stepping stone to making sure that we can improve patient outcomes in the transplant setting. And that's the main thing we wanted to highlight with this study. So those are my quick references. And just a big thank you again to Dr. Stan Radio, who told me that I get gold star. He figured we would just drop this dead once the reviewer is sent back. But I said, no, I'll take it and do the Photoshop crying and do the work. And also thank you to NAP for allowing me the opportunity to talk tonight. I appreciate it. And any questions from the audience? I have two. Yes, Dr. Lindy. So, variable. We went back and looked. There was evidence that referenced to the disease process, so it went along with what they were saying, non-ischemic, but not all of them did. I think like 50% had that within medical record data. So we tried to go and correlate that as well.
What's the correlation between cath lab data, CT angiography, or other angiography and pathology findings? Is my first question. My second question is what are the common reasons clinically for an ICM patient to go straight to transplant and not have it open? Wondering about confounding factors that predispose the population. I just want to know why someone doesn't get an LVAD bridge.
I don't know if that's really have the answer. Okay. Like the clinicians. Oh, no, you're good. You're good. Yeah.
You always have a spare bag. You get a match, you could be a match.
Yeah.
Also, it's for some of them that don't bridge, they're in pulmonary heart failure safety.
Okay.
Yeah. So it might just be the actual state at which they're found. Yeah.
From my experience, that was looked at right.
Hmm.
Even though I asked about CAT data is not necessarily accurate because we've had 0-degree narrowing called on a 90% included vessel.
Yeah.
And sometimes, and I watch the same thing through the charts, right? Ischemic to non-ischemic, ischemic to both, and all over the place. Is as we're looking at these predisposing factors with our hyperlipidemia and our hypertension, which hypertension is in and of itself predisposes you to the atherosclerotic coronary disease. You wonder what their actual disease state was prior and
Right.
with presentation, the actual presentation, especially for those that are going for essentially burnt out hypertensive cardiovascular disease, as opposed to say your giant cell myocarditis or stuff.
Yeah, process.
Yeah. Right. I'm done.
Just to amend this question, Renee, and I congratulations on taking it and actually do the Photoshop. Well, I probably failed. I would have failed months before, so you guys did a good job. Were you, so the quantification you did here,
Yeah.
that was actually worst spot in
Right.
a cool.
Yeah.
Did you correlate with like number of vessel disease, other stuff like that, or was it like what?
We did not. Now, yeah, so it was kind of scattered across the board, whether, we saw, 90% in all vessels. And, some cases even though we only looked at the three, how radio works. Sometimes he'll take sections of everything from obtuse to, all the different branches. So we didn't perform that. So I can't necessarily answer it, but it is a good thought. Was there a significant difference between those that had diffuse or multi-vessel? So it's a consideration. Yeah. Yeah. Thank you. Yes, Dr. Tadros. You can't what? Understand the comparison. I have, right. And right. We don't really have an answer for it other than perhaps it is just a nature of the data set. Is it something that would reveal itself if we had a larger sample? Perhaps. I mean, I think a lot of it is not answered. Because yeah, you would expect, like I said, just based on the physiology of time, that this should go up. I understand. Yeah. No, no, you're right. You're right. It is going down. And when we presented this at USCAP, that was the biggest thing that we met with all the people from the Cardiac Society coming around saying, this doesn't make sense. This doesn't make sense. This doesn't make sense. And we kind of just said, it's what the data shows.
Surviving that long, that's some form of, I don't say accommodation.
It's like some remodeling or something. Sure.
Selecting. Living 24 months, who can live for 24 months.
Sure.
So there may be a degree of selection bias as a result.
Sure.
That you can't control about
Right.
that, yeah.
I think it opens up a lot of interesting additional questions and areas if you have time.
Yeah. To delve into the physiology behind why. Right.
That so many different. So, like, I would guess it would be really interesting too to see the split out between what their ejection fraction was. And it would make some of their echoes to see some of the wall motion changes.
Sure.
See, sort of making of a, that to greater than 2 years versus the 3 months, like what was their baseline?
Sure.
Sitting at, considering the correlation of those that are at the 10% ejection fraction with global hypokinesis versus those that are sitting 35 to 40 and just a bunch of other underlying conditions that are making them unable to compensate.
Right.
Could have a lot of fun.
Yeah.
Yeah, it's
Yes. Oh.
It's the physics teaching us about this, like the shearing force of the blood. Of the blood with the coronary, because that's might be the reason of this weird result.
Right.
I think part of the atheroma formation is because of the blood flow. That's it.
Correct. Yeah.
And we like to look at what physics tell us about the blood flow versus the atheroma formation.
Right. Looking at actual continual flow versus a lack of flow. Yeah. It's an interesting concept. Yes, Dr. Ewell.
Are the picture from whole dark images, which magnification do you use? 40x, 20x, like how do you?
So they were all 40x that we took as static. Yep.
That type or the same picture?
It was just visual. So those were all based off of Dr. Radio's original. So had his visuals and then I performed my own quantitative.
And sending.
Yeah. And then the digital. Yeah.
I said to him, hey, how can you describe the Hodgkin lymphoma by his naked eye in 1800? And he was right 100 years ago.
Yeah.
That's it.
Right. Thank you. All right. Get that out of the way. Thank you.
Thank you.
Yeah.
Okay. Next, we'll have Dr. Lee from Creighton. Pull up your presentation quick.
Okay, but you want to take these,
There we go.
So, yeah, good evening, everyone. And yeah, some people here know me. If you don't know, I'm Shuai Li. as a resident, also gave me a clinical instructor title at Creighton University, Department of Pathology. And I have their FAHA, there's a fellow for American Heart Association. So I'm supposed to be able to answer some of your discussion, but I'm on the vascular side, not the heart. So I basically don't go to those like heart failure people's conference. I don't I know minimum about those. So please forgive me about it. But I'm so glad today I'm going to talk about something also cardiovascular. So not in the heart, but coronary artery disease happening somewhere else. Okay. So I'm going to talk about the ischemic myopathy and the correlation between myofiber autophagy and the patient clinical function in peripheral artery disease. And no disclosure, please. So peripheral artery disease, or PAD, and affects over 200 million patients globally, mostly elderly, and is characterized by this time is atherosclerotic nailing occlusion of the major. Most time people talk about limb inflow artery, but it's peripheral, so it can happen in the arms. But we focus on the limb that most of the situation. So it's not necessarily has to be like a completely occluded. It's like more chronic situation. So it's different conditions than coronary artery disease. Yeah, coronary artery disease most time is acute, and so this like occlusion of the limb inflow major arteries cause ischemia, and ischemia cause hypoxia. Hypoxia and ischemia together cause tissue damage. So entire downward of this blocked or narrowed major arteries, all the tissue are damaged, and at the early stage PAD is defined by like clinical definition called claudication. Basically means walking with pain, and because of the pain and discomfort, the walking performance is limited. However, when it's like an end stage of PAD, later stage, there is called chronic limb threatening ischemia. So even without walking, just resting, there's a pain. And if there's a wound or ulcer, it will not heal. So it's called ischemic ulcer or something. And this non-healing wound or ulcer eventually leads to amputation. So what do we know about the damage, tissue damage in the peripheral artery disease? We know there's muscle, there's skin, basically everything in the leg will be damaged. That's part of the disease. Now, for the muscle damage, it's relatively more started, still quite understarted. It's like we call it chronic ischemic myopathy in PAD. That's how like American Heart Association people call it. I don't think pathology has a clear definition of the myopathy in ischemia in this situation, as far as I know. Maybe I mean, neuropathology can correct me. Yeah. And for the skin damage, people here, some people know I'm interested in dermatopathology, so I look at skin damage. That's actually easier to identify. There's classic skin change. Skin become like smooth and loss of hair follicles and get thinning, shining. And if there's a wound, it's very difficult to heal. So it's most time happens on the like a stressed or physical challenged area. Most times in the lower foot or ankle if there's like a not fitting shoe or some reason. So we have this ischemic ulcer and cause gangrene and cause amputation. That's a skin damage leading to this like a mortality. And for nerve damage, it's not well started, but there should be nerve damage. Vascular damage is a vascular disease. There is a vascular damage, and still, not well started in my opinion. And the local inflammation also happens. So from my years of research, I've been doing quantitative, like computer quantification, yes, and of the fluorescent and the light microscope to evaluate the damage. So use like statistical numbers. Look at my pathological morphology change. You can see here from left to right, non-PAD muscle. The brightness here, a fluorescent antibody targeting for marker for oxidative damage. So the brighter it is, the more oxidative damage there is accumulated. So compared to the non-PAD control, the moderate has more damage and some morphology change you can observe and appreciate. And at the severe PAD myopathy, there's definitely more like oxidative damage and also morphological change. And we also did tissue fibrosis with mesenteric staining, did quantification. And the mitochondrial damage, we have those machines can just evaluate mitochondrial function at the same time. And so, oh, too much. Okay, go back. Yeah. So some published data with our collaborators or some unpublished data from ourselves look at neural and vascular damage. Here's this year's publication looked at neuromuscular junction damage on the right side. So from top to the bottom, compare different patients with different level of peripheral vascular disease, peripheral artery disease or PAD. So the neuromuscular junction got disformed and decreased in number, and it's basically looks like damaged. So, and it's been published in the neuropathology journal. And for the left side, left lower, there's some our unpublished data still looking at the brightness of oxidative damage. Look at those small vessels, those capillaries got both thickened with more collagen form, more basement membrane, and also accumulation of oxidative damage. That's not surprising because the entire life got damaged like that. So for myself, I had a KO8 grant looking at mitochondrial in peripheral artery disease. So, and I'm interested in both muscle damage and skin damage. So the upper panel, like earlier I talked about, there's mitochondrial damage. One of our theory or my theory is like mitochondrial damage plays a central role of this accumulation of oxidative damage because oxidative damage, mitochondrial leaked more oxidative damage. So it's like a worse positive cycle happening. So what is the mechanism that people can deal with damaged mitochondria? There's not only one, but the major one is mitophagy. So autophagy to recycle those damaged mitochondria so that it doesn't leak anymore, it's recycled. So I look at pink one is a marker for mitophagy. Upper panel here is like compared to control early and end stage. We found very interestingly, in the early stage of PAD, the mitochondria did not go up to against the damaged mitochondria. Instead, it goes statistically down. And that severe damage, yes, it looks higher than control, but not statistically really up. Increased to counter the damage. So that's interesting. That means even at the early stage, the mitophagy cannot work up toward the accumulation of damage. And a similar observation, not surprising, happened in the skin. Like look at the epidermal mitophagy, like pink one marker in the end-stage PAD patient's limb. This is at the stress or weight-bearing region is statistically less mitophagy than is supposed to be in the control skin. So what's the current therapy for PAD? Most time we do it. Of course, we start with preventive care. We don't want this disease to develop. But once it's developed, for the supervised exercise treadmill therapy, called CyTime for now. It's a first-line therapy for early-stage PAD. So we don't want to develop. We want to recover from the walking performance. So it's directly supervised by a qualified healthcare professional. So, yeah. And training for a minimum of 30 to 45 minutes for 1 hour and 3 times per week for a minimum of 12 weeks. That's approved by Medicare. And walking to the moderate to maximum claudication pain or discomfort to a level people can't walk anymore, they stop, or you finish an entire session. And this is covered by Medicaid and the commercial insurance. That's everybody coming in with early stage PAD as far as they can walk, go through this. If it doesn't work, then revascularization means either by standing or major surgery can kick in to try to help the patient. But that's a big surgery and it costs a lot of money. So I understand it's not first line. But if it doesn't respond to CyTime, the revascularization is a therapy. And if it's critical limb straightening ischemia patients, surgery is the only way to help them for now. So we did a CyTime study and looked at what's total of 41 patients. And based on the look at histology, screening histology, no other quantification. This time is pathologist eye. Just 2 subgroup of patients can be easily identified. Group 1 patient, we can find that, okay, just 6 months, it's pre-post 6 months, after this exercise therapy, so much muscle damage. Like you just cannot ignore it. It's exacerbated. End-stage kind of myopathy happened in a short period of time compared to it's like normally it takes much longer to develop to end stage. And the group 2 patient, like just minimum change or there's no change, like at least for bare eye we cannot tell. So patient clinical function, muscle histology, osteodamage, fibrosis, and I'm interested in autophagy, so I look at autophagy evaluated in this 2 subset of patients. So when we look at clinical hemodynamic and clinical measurement, we found that for those people we identified with severe progression of myopathy on the left side, they did not really improve a lot. What they improved is only the claudication onset time, the COT, and the peak walking time. Those are how they perform on the treadmill. That's the data supported, and people publish a big paper, and so everybody say, oh, okay, exercise treadmill is great. So that's the data. We're consistent with published data. Yes, they walk better on the treadmill. However, their 6-minute walking distance, SMWD, like they free walk for 6 minutes, their walking distance is borderline decreased for this group of patients. So yeah, muscle damage does reflect to their daily life. And they like a week is like a walking impairment questionnaire. Those last 3, those how do they feel about their daily life? Their pain, distance, speed did not improve. Even they can walk better on the treadmill. I mean, train myself on the treadmill for half a year. I can walk better on treadmill and get used to it, right? And but yeah, and for the other group, actually, when there's no like muscle damage histologically identified, the other side group with no or mild disease progression, they actually benefit from exercise. I'm not saying exercise is bad, but depends on who you are, I mean, who this patient is. They walk, their hemodynamic is even better. So that means it's some exercise to certain people, their blood vessel get benefited. So they can function no better, and they also feel like their life got better. So, and then I looked at quantification, yeah, computer, and the upper panel is oxidative damage, lower panel is like a mesenteric staining. We look at just blue color, and then again, computer just filter it out, only blue color, see how much fibrosis there is. And there's significantly increased of oxidative damage for this like damaged group of patient. Okay, the other group is not significant, and the fibrosis also increased. And here I can also appreciate some like morphology change and accumulation of oxidative damaged protein in the center of the muscle. Yeah, and so what is its histological features? What are the key features observed in this? Like I'm thinking I need to characterize it. And maybe this finding, if I characterize, can reveal the underlying muscle injury mechanism. So in this, we know it's understudied myopathy situation that potentially can direct our clinical intervention by a pathologist started. So fibrosis is the easiest one, consistent with what I talked about. And this time I did not just number of like quantification. It's like my observation of percentage people with clearly increased, I mean, easily identified increased fibrosis. There's significantly more people and consistent with quantification. So again, pathologist, maybe not yet, but pathology trainee's eye is consistent with quantification, computer quantification. Yeah. And there are all kinds of muscle damage characters. So I read some literature and see if I can observe different kind of reason already established the mechanism for certain kind of muscle damage morphology. This atrophic and angulated myofibers and grouped fiber atrophy, both a suggestion of neural damage. And on the left side, we can see those like atrophic angulated myofibers, smaller myofibers in between those polygonal normal looking myofibers. On the right side, you don't have pointer, but you can find there's some grouped nuclei, very shrinked myofiber. So that's like a whole group of myofiber atrophy. This suggests of neural damage. So consistent with what I thought. And we also found some patients like developed a perivascular atrophy. So that suggests of vascular damage totally makes sense. I mean, there was a vascular damage to start this. And toxic damage just tissue necrosis for some reason. And I called it myophagocytosis or all necrosis because actually most cases we don't have really a lot of macrophage in this situation. So maybe not exactly myophagocytosis, but necrosis, we can observe that by muscle damage, like almost 60% patient of this patient developed muscle necrosis. So also significant. And the central nuclei is a sign of regenerative myofiber or regeneration. This also increased. That can be, well, figure is not that big, but there are some myofibers clearly like with small central nuclei, the myofibers number. So that's also significant. And for myself, I'm interested, I have the funding and look at autophagy and lysosome. There we did different staining. Inclusions is actually difficult to really tell exactly what inclusion it is. So, there, in neuropathology, are different names. I think the mechanism is slightly different here than the classic autophagy or lysosome damage disease. It's different because those are like mutations. It's like accumulation of damage that's jammed the autophagy and lysosome recycling system. So the mechanism is slightly different, it looks slightly different, but still both I would say some like target node or target lesion. It should not be that name, but basically accumulated autophagy marked protein is there. And also vacuoles sometimes. Some muscle has vacuoles as a sign of the autophagy lysosome damage. And lower is like I did a P62 and LC3. LC3 is a marker of autophagy. P62 also a marker of lysosome, but if P62 really accumulated, means the degradation is not happening. Those muscle, like all tissue of cells, lost their function of recycling protein. So they're all consistent with autophagy and lysosome damage. Then we look at those like again mostly my say subjective evaluation. It's also consistent, supported by our objective, just like quantification of myofiber size. In the left side, the patient with severe disease development, the myofiber got shrink in size. There are bigger variation, bigger standard deviation. So like not homogeneous, like become more variable. And aspect ratio is increased, means more angulated myofibers. And oxidative damage is borderline increase. And the collagen, like the same like fibrosis is increased. And if I look at only lower quartile myofiber inside, only look at smaller myofibers, those are mostly affected in this kind of situation. The myofiber size significantly decreased and oxidative damage significantly increased in the myofibers. And on the right side, those people benefited from exercise. Their myofiber size slightly increased, not significant, but going that trend. I can't say that's just definitely beneficial, but at least that's opposite than the other group. And for the smaller myofiber actually get larger. That's significant. So maybe they did benefit from everything. Right. So how about the revascularization? I did autophagy study on the revascularization. I want to know if autophagy is related with patient function, autophagy in the muscle related with patient function. So we recruited 29 male patients with stage 2 PAD, one male because it's from VA hospital, basically. And with claudication early stage, undergoing revascularization, use immunofluorescence, look at LC3, already talked about this autophagy marker, and also oxidative damage indicator. This time I look at the carbonyl groups. And correlation, I use LC3 to the oxidative damage ratio as how much autophagy in response to the accumulated damage. It's one of the indicator. So correlation between these with the clinical function, and thanks to Thomas already talked about statistical analysis. Depends on situation, we use the appropriate analysis for it. So that's a sample picture of stage 2 PAD patient. That's their muscle morphology looks okay, and look at their like autophagy and oxidative damage level. And I found that the change of autophagy is associated with improving clinical function. Sounds better. Basically, for those patients with more increase in autophagy response, they performed better in their clinical function after 6 months after revascularization surgery. So ABI got better, and change in 6-minute walking distance improved, correlated, and time up and go decreased. And then they say these three are like yeah, subjective. Their how do they feel about their life? Their pain score, they feel like less pain. They feel like walking distance better, and they climb stairs better. Yeah. So that's a summary of those data. This all the statistical analysis result. There's some data is not significant. It's also showing there. So summary is a significant portion of PAD patients, almost 40% of PAD patients developed exacerbated end-stage ischemia myopathy after this current standard therapy for them. And this features SATM induced ischemia myopathy include, like I mentioned, fibrosis, atrophic angulated myofiber, group atrophy, all these things, and also a sign of autophagy and the lysosome damage. And this suggests that ischemia, neurogenic, and autophagy lysosome damage to play key role in this very quite distinct understudied myopathy. And I believe pathological evaluation is critical for identifying muscle damage and guided revision of current therapy. I've been talking about this to a group of people, and some people start to change their practice, even that's not the suggested one. Yeah. Hopefully sometime later, internal medicine people will listen to this. Yeah. And patients with revascularization induced increased in myofibrosis autophagy respond to damage are linked to improved clinical function. So that means the future direction, one of the future direction is like look at the mechanism why these two group of patients perform differently, so much differently. Answer is I don't know. And we look at clinical demographic factors, if anything determine it, we didn't find it. Genetic or genomic variability possibly, but it will cost a lot of money to screen this patient, and maybe it's the environmental and the lifestyle factors they didn't report in the IPIC, we don't know. And we need more detailed study for this, and also skin damage, because I like skin dermatopathology. So we need to propose and modify customized current exercise therapies. Exercise still good, just don't be customized. And we need, if there's novel therapy to improve the autophagy and mitophagy, maybe we can treat early stage PAD patient to improve their clinical function, can help the exercise or just help their generally life like quality. And well, more study in autophagy and mitophagy and dermatopathology just because of my personal interest. And acknowledgement to the neuropathologist at Creighton University, and the vascular surgeon at UMC, and the team members, my funding from American Heart Association, Viva Physician, those are the internal medicine people actually. Yeah, they do interventional. And CSATR, or NIH, our department and collaborators and institute. And thank you. And that's right now this pair of my favorite autophagy in the epidermis of PAD patient graphic. And questions?
You don't need biomarkers to predict which patients is gonna get bad effects from this science? I initially thought about a hemodynamic factor, like how their blood vessel actually functions could be the predictor. It's actually significant, but I'm not sure if that's really gonna tell them apart, because if you really want to tell them apart, you need to run the ROC curve and find the cutoff. I don't have that cutoff yet, so I cannot tell people, oh, that's something you can tell them apart. And try some tissue. Yeah, I have the tissue. Yeah, like I mentioned, I want to do the genomic analysis. It just costs too much money because I don't know which targets is gonna be the fact. I need to do a whole genome, like a sequencing or something, at least an exome some sequencing. I got our Nebraska University small grant to do some patient, but that was
what is going to blind with content. That's what we should do. We should give the real most sample and you do proteomics. And whatever marker is gonna come from the protein analysis, gonna be your biomarker that you will sell as okay.
Yeah.
Give me a biopsy from the muscle before you going and make this exercise for the patient. I can tell you it's gonna be more better and you will get funded if you
Yeah,
if you
yeah,
make
that-
the story and development of biomarker.
Firstly, that's a good idea. Actually, we did submit our one for this, and not everybody like this idea. There are a huge group of cardiovascular related exercise promoter that does not want this. You know, that's a real life thing. But you're right. Like, if I find any biomarker.
For a group of diagnostician, not cardiologist or like vascular surgeon.
Yes.
Because they are not gonna appreciate the science. But if with this amount of data, you just submit it for one of the grants that are promoting diagnostics and telling, hey, I can develop a biomarker that can save these people.
Yeah.
They are gonna fund.
Yeah. If I have more time, not as resident, probably I would do that, especially from American Heart Association. They really love my idea.
I think.
Yeah. We are still. Yeah. I'm still working closely with their group. I'm still an instructor in there. So yeah, we definitely.
Have you tested the pH post and pre?
pH. Okay. Yeah. Well, that's probably would be some idea my previous collaborator would do. But he retired. I can ask him if he did that.
But the link, the oxidative stress, the autophagy, the missing link here is the pH, which usually gonna be associated with hypoxia. I mean, why? If I see this data, I will tell you, okay, the skeenness causing hypoxia, acidity caused by blood.
Yeah.
But
Yeah.
to prove this hypothesis, you have to check for the pH.
Yeah, I agree. That is true.
Going down now.
Oh yes. We all go down. That yes, you're right. Yeah. Is that good enough as biomarker? We will think about that. Put into our next proposal as one of the parameters to look at. But like I said, probably Dr. Cassell has looked at it. I need to ask him if I ever looked at that before. Yeah. Mm-hmm. That is the thing. This samples recruited by a huge 2-hour one, so together $10 million spend. Yes, we have a very limited sample, so very precious sample. Yeah, both frozen and the block, pre-treatment, post-treatment. Yeah, we looked at it. We didn't find it in the parameters we looked at, but right now we kind of don't know exactly what else to look at. That's a problem. Yeah, we observe pathology, we observe what we are interested in, but then the baseline others for the early stage PAD in the baseline they all look the same basically. But all the parameters I looked at they all look the same. This after therapy, some people different. I still think it's probably the small vessel damage is the thing. We did some study look at the oxidative damage and the capillary collagen deposition. I'm personally thinking I should look at that in more depth and see if that's a predictor because muscle looks similar, but their perfusion under exercise may be different. Some people got a good perfusion, some people not. That's something we definitely need to do. As still needs a lot of time, and we used to have an MD PhD student look at part of it, but didn't have a chance to complete the entire thing. We definitely should do that. we definitely should do that, especially for those damaged myofibrils. There will be a lot of like electron microscopies. I should ask, do we have time and money for that? I think we just got another grant doing a pig model, so probably we can squeeze some money, at least look at the pig model muscles if that's happening. Yeah. That's odd. Yes.
That's scary. What we talk about is ischemic
Yeah.
injury.
Mm-hmm. Yeah. That's very true. Still, I mean, direct to the point. Like, why exercise cause this patient damage? My theory is like I said, those smaller vessel reperfusion. I mean, perfusion is not like continuously like, when exercise there should be dilated, better perfusion. But some people, my theory, they're like when exercise, they caused more ischemia because their vessel did not dilate, small vessel did not dilate as it's supposed to be, and then cause reperfusion damage because of ischemia. And then later when they rise, and then blood flow down there, and then called just like heart cardiovascular damage. That's actually the theory, my theory. Yeah, one of the reasons. Yeah. Any more questions? Sure. You mean the exercise patient when the yeah, yeah, it is standardized, and we did consider there's change maybe right after. It's not right after my exercise, but how many days I need to go back look at the IRB? I think it's 1 week or within 1 week. But in the real life, is yeah, maybe there's some like variability there when the patient really willing to come back, get another big piece of muscle cut out. Yeah, it's like need to talk them into this. So even this number of patients does not look like huge, but it took a lot of effort to recruit. It was not easy. Yeah, and probably we are the only, not only, but limited groups that really has this sample. So that's treasure. Yeah. Okay. Thank you. More questions? No. Okay.
All right. Well, thank you again to both presenters. Well, can we get another round of applause for everybody? And then we'll have Tanya go ahead and give the group the financial statements, and we'll move on to the business meeting portion of the event. So just a couple of administrative updates. Here is our current membership for the past 8-ish years. As you can see, in 2017, we were at 134. We began to see a pretty sharp decline, particularly around the post-COVID years. And then moving up starting in 2023, and then kind of steadily moving in the right direction this year. So again, thank you all for being members. This is also a testament of you guys as well as to how well you're promoting not just the events, but also the association in general. And then as from the financial statements, you'll see that we're also, oh, I'm sorry, hold on. I need to make sure sorry, Zoom folks, I forgot to share the screen. Okay. Sorry, we have 3 members on Zoom, so I want to make sure that they can see what everyone else is seeing. And then as far as a financial statements, you can also see from 2019, that's the year that we started I started particularly working with you guys, and we've made pretty huge strides in making sure that we're financially sustainable. So when we started in 2019, our bank account was at $354. And you could see that steadily increase throughout the years, yeah, even through the COVID years, which was, you know, a huge surprise on my end. But we've been able to just steadily increase to the point where we're at 43,434 and 63 cents. And I've given you guys all copies of the financial statement. So if you have any questions, I'd be happy to answer any of that. The biggest expenses for us tend to be these events. However, we do get exhibitor funds to help fund all of these events. So I appreciate every time that you guys get to interact with our exhibitors. It makes them want to come back and help us afford these dinners. And then obviously dues is the next biggest source of income. And then as far as expenses, it's also our time at the Nebraska Medical Association and managing the association, and then these events as our biggest expenses. The other thing I wanted to discuss is that because we've been able to be more financially sustainable, we can finally help support trainees who want to go to and travel to a national meeting. And so that travel scholarship application will be live shortly for the spring event at CAP. And this will be open to both residents and fellows. And it'll be $1,500, one for each program. So start thinking and looking at your calendars if you guys were planning on attending. This is a great opportunity to help fund your travels, and just, you know, a little something else that will help you get more exposure to national conferences. From an NMA update, on the legislative side, it was a very busy year for us. Probably our biggest priority was prior authorization. That was LB 77. We were able to pass a prior authorization bill. It did not include everything that we wanted it to include. As you can imagine, the insurance companies gave us a pretty big fight in terms of what they were authorizing. Some pretty big wins include limiting the number of days before they have to give us or give you guys a response. So 3 or 72 hours for emergency, prior authorization response, and then 7 days for non-emergency authorizations, and then having a peer-to-peer review. So your first denial does not have to come from somebody in your same specialty, but then if you appeal for that, then it does have to have somebody within your same specialty make that review. And then any emergency services do not have to have prior authorization. They just kind of go through. So like I said, not everything that we wanted, but it's baby steps when it comes to insurance in Nebraska. They have a really good lobby, as you can imagine, probably across the country. And this is a very insurance friendly state. So just even getting that bit was a win. The other thing that we had going on was Medicaid reimbursement increases for physicians. The Nebraska Hospital Association last year passed one for hospitals, but this one on our end was for physicians. That was approved by the legislature, signed by the governor, and basically the funding will come via, we don't call it a tax, but it's essentially a tax on the insurers. And that just needs to get approved by the federal government, who at this time is not working. Or I think I just got the alert earlier in the day that they might have reopened. I'd have to check. But once they get opened and start working through the applications to allow us to have those assessments on the insurer so that we could then draw the funds and provide that Medicaid reimbursement increase, we'll be able to notify you guys from the medical association that that's going to go through. And then the credentialing review, in Nebraska, we have a process called the 407 process, and it's how health professions, and not just basically all of your allied health professions, get to establish all of their scopes of practice. It's a 3-part review. The application goes through a technical review committee, it goes through the Board of Health, and then gets a final vote from the medical director for the state. There's been a recent push to do away with that entire system. And one of the bills that was proposed would then give each board of each allied health profession authority to define what their scope of practice is. So as you can see, or you can kind of take away from that, is that then optometry would be able to decide what optometrists scope of practice would be. Nurses would be able to define what nurses and nurse practitioner scopes of practices would be. Physician assistants are under the Board of Medicine, so they would be kind of insulated from being able to do that. But anything from, techs to, take your pick of allied health profession, their own boards would get to decide what their scope of practice is. So when it comes to patient safety, this is a huge red flag for the medical association, and one that we obviously went to fight against at the legislature. The bill stayed in committee. However, because we're going into the second part of our biennial cycle of legislature, then that means that at any point they could call a vote on that piece of legislation to try to move it towards the entire legislature for then a vote at the level of everyone. So kind of a scary thought. We'll keep you guys kind of informed if there's any need for us to have a calling campaign for all of our state legislators. But that one's definitely one that is scary from a patient perspective, and obviously from a physician perspective from you guys. And then if you recall from our spring meeting, we also had LB 632 that was more specifically affecting pathology. And that one requires the healthcare facility to dispose of the remains of aborted unborn children. That was introduced by Senator Hansen. And he basically wanted any elective abortion, undefined in his bill, to basically force all of the healthcare facilities to either bury the remains or cremate them without any regard for whatever the mother of the aborted fetus would want. For pathology, we were concerned because due to some medical indications, sometimes the standard of care is for a pathological examination of the remains to basically understand if there were any complications that you would want to let the patients know for future pregnancies. And so sometimes that means that there are no remains to bury or cremate. And so that bill actually did make it out of committee. It's currently on select file, which means that at any time they could call for a vote from the general legislature. They did make some changes to the original bill. Still did not quite define what elective abortion meant. It's a little fuzzy from the way I read it, but the parts that they did include is that it would not cost the family or the patient. So the institutions would absorb those costs. It would also, there is now a requirement that they have to tell the mother which they didn't have to do. And so now the mother can decide if they want a cremation or if they want to bury the remains. And so this is one that will probably get a vote at the level of the legislature. So once the legislature starts, we'll keep you guys informed. If you have more specific questions, I can put you in touch with our legislative VP of advocacy so that he can help you guys craft any letters or any kind of testimony that you guys would be willing to do over at the legislature. But we'll keep you guys informed of this one because it specifically affects pathology. Do you guys have any questions on the legislature or any of the processes that I've discussed? Okay. Then Dr. Teichmeyer.
See the updates. It's the last big thing was the FDA final rule, which is no longer going into effect. A quick search of my advocacy emails, I saw that there was a Medicare pay cuts to pathology as part of a bigger bill and bundle time, but it seems like every year there's some. We're fighting for you from the CAP at Washington. It's always so it's outside of that, I guess today's like the CAP member appreciation day. You see an email in your inbox, there's some new offerings they have members like an on-demand lecture series for anybody who has membership, and there's actually a mentorship program they started, which the committee that me and Allie here are on, we actually helped craft that mentorship program. So want to get in touch, or like me learn from some other pathologists that's available online as well. So figure I got the stage, I'll plug that for a second. So other than that, no way to see it set up.
Okay. And then as far as our advocacy breakfast, that will take place on February 6th, 2025. And you guys will all get an invitation to that if you're a Nebraska Medical Association member. And then speaking just of the Nebraska Medical Association, did want to thank Dr. Robert Wergen over there in the back. He's our current president and has been very diligent about trying to meet with all of our the specialty associations that the NMA manages. So thank you, Dr. Wergen, for being here. With that, I'll open it up to any questions or any comments or anything.
CHOP scholarship members of the committee. That's meant for trip for advocacy. It's not meant
Yes.
for USCAP or a research project or the typical.
Correct. Sorry about that. Yes. It is for advocacy training for residents. Yes. Yes, Dr. Wergen.
You present fellows get a lot of more than us older guys. Because they gotta know their futures. And younger fellows, they are 30 ready that have to come down. I've seen that a lot, you get a good turnout. A lot of they they're giving me about they should. Feeling your appreciation. I don't think that I encourage you. And it's just for that one, have to take off that one. It's over pretty quick. We usually were trying to bring a white coat and over the legislature, whole section, they have white coats on.
Yes, it is a very unique day because we do get to speak with a lot of legislators as well as their staff. And so, we are able to kind of present our point of view from the medical standpoint. There are no physicians on the state legislature. So, yes.
Reconciliation bill had $1 million rural active portion to it. We were part of the input to our state just department. And well, I said predictions are difficult about the future, and
you don't know how it's gonna turn out, but, it looked like we might get more than, each state was gonna get $100 million. And depending on how CMS looks at it, you can get more. That's over 5 years. It almost looked to me like they were expecting, you're very favorable, you're red state. You might get $200 million. The reason I say that is directed at rural centers like mine, and you in pathology, we have to reach out to you a lot. Some of those centers have disappeared. Some way, it's gonna shrink. But maybe all that pathology business is from the urban centers. Curate to see something happen. Care facilities along the Warner Trail.
So quick question about that, thinking about the forensic society too, because one of the big issues that we face is rural access to medical death investigation. It's actually Nebraska was having a recent NASCM report looking at that's in custody and the structure of our system. So I guess my question is, given the fact that you cover a very wide swath, and it's both now there's only 3 forensic pathologists that are in the entire state. Is it possible that some of those funds would be able to be funneled toward the medical legal death investigation side that help improve that and help our public health data that help bring us more money? Or are we sitting, or is it really focused at, providing greater access to rural communities, which granted there's major deserts out there across the state?
Well, my answer would be that there wasn't any mention of that in the bill submitted. If you're gonna get my interpretation, from I could tell they were catering to the Maha and Kennedy, because it's a big chunk of it was to dietary food programs on the table. It looked like 20 million here, which should be a lot of money you get. But I think it was so they would likely get picked. Something like that, there's some borderline kind of, but my suggestion is that that's all they would try to write up a grant for some of the, because there was a little bit more money in there than we applied for. And maybe it's just CAP people draw up a grant, they sort of, it's got to be specifically grant. And you got to put little twists on the community page and all that, you like that stuff. I know EMS people are that way too. We're going to hit an EMS, and they're soon too. They're getting the car accident, or that might have a ways to go. We won't be that, but that would be something that would pertain to that. My suggestion would be see what the bill comes back, what the money is. The president, someone could write up the grant, try to run through it. We at the NMA, Paul was really good at knowing out what words to say with there. I will say all our income that went to this application, almost we focused on really, we did rural emergency care and that had struck out. The final proposal. That's why I saw the dietary. I don't know the final, but something very huge on Stanwood, Calvars and schools, farm potatoes, and all that. I think it would be a political to the Baja Grandma and HHF. They're the ones that CMS is to get the other things from how much money. We got
CMS, but yeah, who is the audience? Yeah, so
CMS, I think there might be an opportunity for you, but then that's sort of reasonable. And you could team up with them. They like other engagement, like law enforcement, maybe with you. I'm sure.
We work very, very closely because they're essentially our gun investigators.
Yeah, so I would say emphasizing the limited, maybe add another fellow in their state or do, whatever you think that would help that situation. But you have to see how much money is left over. Sometimes when you get $200 million in the 5 years, you've got enough for forever. I was amazed how many people, so, and it intense interest in me in rural Nebraska. Most, even the COVID vaccine came out, our Fort County area, and they hear about that, and we're trying to skim off some of this pre-hospital personnel. So we're kind of ignored it now, we're real poverty. We might be $250. Judy O'Gordo like me more, our next president.
Any other questions or comments during open forum time? All right, seeing none, I guess we're adjourned. Thank you guys so much for coming. Oh, wait, we have someone on the chat. Oh, thank you. Thanks, Dr. Lintel.